Good morning. This is Dr. Chad Versio. I'm the chair of pediatrics here at Riverside University Health System. Glad that you've joined us this morning and hope that you'll find this information helpful. We're lucky to have with us this morning Dr. Bruce Wang, our infectious disease physician here at RUHS, and he's going to be talking with us about the use of Remdesivir and how we allocate this very scarce resource. So first, before we get into that, we are going to talk a little bit about the overall state of the county. In Riverside County, we have tested so far 106,000 people. About 7,000 of those have had positive tests. We have 193 currently hospitalized COVID positive cases and 63 in the ICU. Both of those have trended down just a little bit, but not dramatically. Over the last 2 weeks or so. And then we've had 303 deaths across the county so far. You can also see, a very nice graph on the county website that shows the number of new cases and total cases. It's very helpful as well. So San Bernardino County, there have been 4,567 positive cases in San Bernardino County. Their doubling time is a little bit shorter than ours is, as theirs is still about 15 days. They have 176 deaths across their county as their increase started a bit later than ours. And then they've tested about 55,000 patients so far with an 8.3% positivity rate on their tests. Their hospital census, they have 139 COVID positive patients. They have 103 suspected patients. In their ICU, they have 48 ICU positive, COVID positive ICU patients and 22 PUIs. They have some graphs there as well on their county website that shows that haven't had a dramatic increase since about a month ago. Things have held pretty steady over the last month for both the ICU and overall confirmed positive cases of COVID. So now I'll turn it over to Dr. Bruce Wang, and he will walk us through the Remdesivir resource allocation process.
Thanks, Dr. Versio. Good morning, everyone, and thank you for joining us for the webinar. Let me get my screen shared here. Also make sure I close everything else here. So, as many of you have heard in the news and reading online and just
sorry to interrupt you, Dr. Wang. I'm still not seeing your screen yet. I don't know if others are able to see it.
How about now?
Yes, and then if you don't mind going to press play, and then we'll see the, for the slideshow, press play, and then it'll show just the full slide.
There we go. All right, looks okay.
Can you press play on the slideshow? Because it's still just showing the, if you, up at the top, if you go to slideshow, there, and then in front of you, there you go.
There we go. All right. So thank you, everybody, for joining us this morning. I'm going to be talking about Remdesivir use, the challenges we've encountered here in the hospital, and also to give a little bit of feedback, just talking to other facilities, not only in our county, but in other counties as well. As many of you know, Remdesivir is an antiviral medicine, and the concept is that it's supposed to help halt viral replication, not only for coronavirus, but it's been tested in other things as well, such as SARS and MERS, etc. So the biggest thing with Remdesivir, as we all know, is that it's a really scarce medication and resource. The company, I don't know if stock in it, Gilead, who created it, had a very limited supply, and as we know, initially it was all available through either clinical trial or compassionate use. And once their initial kind of cohort of study data came out showing that there was some benefit in recovery, they actually donated almost all their supplies. They kept some for compassionate use for peds and OB patients, but they donated everything to the government The FDA/FEMA then distributed it to all the states based off of COVID burden, and the public health department in each state then distributed remdesivir to each county public health department, who then looked within their county to decide what was the burden of each of the hospitals in the county, who had the biggest group of patient COVID burden, and then distributed it accordingly based off of that proportion. We were obviously very lucky to receive a small cohort and distribution of remdesivir on the initial batch. And what we did is we actually got exactly 4 patients worth of treatment. And I'll go over the treatment dosing and everything as we go through this, and you'll kind of see the challenges that we ended up meeting here. So that's kind of just a little bit of the background with remdesivir distribution, and this is not just the allocation within California, but obviously with any of the other states that were getting it as well. So just some background on remdesivir, and I'm not going to go into any of the pharmacology. I know there was another webinar with our pharmacy group who had discussed this, but it's an EUA, meaning Emergency Use Authorization. It hadn't gone through all the phase 1, phase through phase 3 studies. And almost all places are proposing is you give a 200 milligram IV dose on day 1, so a bolus dose followed by 4 days of the typical 100 milligram dose. Each vial has 100 milligrams. So in this setting, you're going to be using 6 vials, just to kind of give you some perspective for a treatment course for a patient. A lot of the challenges with the remdesivir and the fact that there was such a lack of supplies was needing to create strict inclusion and exclusion criteria for use. And the purpose wasn't to weed people out or weed patients in, but to try to target the patients that the initial studies had showed the most benefits. And, I could briefly touch base on that a little bit later, but we know that the earlier you use the therapy on patients that are declining, the potentially better response they get. And that makes a lot of sense. As we know with most viral respiratory infections, the active replication phase through infectious phase usually lasts about 10 to 14 days. And I think we're probably going to see something similar with COVID coming out as more and more studies come out. There was actually something recently that came out of Singapore over this weekend, which was also showing this trend as well. So a lot of these inclusion-exclusion criteria were based off of the initial studies that had come out, and I'll go through them briefly. So inclusion, you have to be hospitalized. If you're not ill enough, there wasn't an indication to use remdesivir, and you obviously needed to have a confirmed COVID case. You had to have some sort of a severe respiratory presentation, so hypoxia, 94% or less on room air, needed oxygen or mechanical ventilation. And then we picked symptom onset less than or equal to 12 days, at least based off of the initial studies that had come out. There are some facilities that are even more stringent in using 10 days. Again, that's also based off of a recent study that came out Friday from the NIH. And we do take that 10-day consideration into account later on, and I'll show you. Part of the 10-day cutoff that a lot of the facilities may be using had to do with the recent study showing that the mean time of therapy for the most recent study was 9 days. So that's where that kind of soft cutoff of 10 days came from. Exclusion criteria included elevated LFTs, greater than 5 times normal, so you do have a little bit of wiggle room. And the reason for that is just the way the medication is metabolized here. The GFR needs to be greater than 30, so less than 30 is also a cutoff. And the reason for that is there's a, I guess the best, I'm not a pharmacist, but there's kind of a carrier component that potentially, hypothetically, and at least animal models, noted to potentially cause side effects if your renal function's a little bit low. So that's why there's the GFR recommendation in there. If you're being discharged from the hospital, obviously you're getting better, and there's no indication really for remdesivir. And then the transfer to another hospital primarily is put in because if you start therapy and you're already pending a transfer, there's the thought that you may not be able to complete therapy as well. And, you know, there was a lot of ethics input into this, and this is, last point was something our SSS, along with our group of multidisciplinary committee had made input into. If somebody has an irreversible terminal comorbidity that would really qualify them to go on to hospice at that time, that'd probably be somebody you're not going to be given remdesivir for at that point either. So there was a lot of concerns when we created, well, at least from my side, there was a lot of concerns because I was thinking there's going to be a ton of patients that we, you know, as we go through our COVID positive patients, and this is going to be very challenging when we only have 4 treatments worth of patients, even with these criteria in here that were based off of the studies. So, there we go. So this is kind of just a quick summary of how we approached, how we would distribute remdesivir and take patients. But given the supply was limited, we wanted every decision to be a multidisciplinary decision. So this would be with input from ID, pulmonology, critical care, pharmacy, the primary service. So whether this was the hospital service, family medicine service, you know, if it was a pediatric patient, obviously peds or OB would be significantly need to be involved in the decision. And then ethics was always available to provide further input if there was conflict within decision-making process. And again, they had significantly guided the protocol here. These are some key points that our ethics team had also recommended when you're considering use of remdesivir. So, you know, we want to approach this without really any discrimination. So they included race, gender, obviously ability to pay, sexual orientation, religious preference, immigration status, citizen status, socioeconomic status, disability. So you're trying to be encompassing with everybody and just treating everybody equally.
Dr. Wang, can you go down to the next slide? Because I think maybe some of that stuff was in the next slide, if I recall correctly.
This one here?
Yeah, we're not seeing, for us, we're only seeing slide 3.
Oh, so you have 1, 2, this one here?
It's
the
not
one that's an ethics review?
It's not moving. So it's just showing slide 3 and doesn't seem to be changing which slide that it's on.
Still stuck on slide 3 here. Let me unshare and then share again and see what happens here.
Okay.
Let's see. Okay. All right. Does everybody see slide 1 again?
No, it just shows slide 3.
Oh, that's weird. All right.
Let me try sharing my see if so are you able to see that?
I see. Oh yeah. I don't know what happened there. I was having a lot of staggering when I was advancing slides, so I don't know if there's something wrong with my connection side.
Okay, maybe that's what it was. So, and you were on slide.
We could go to slide 4.
Okay.
Yeah, I think this is. Oh, no, you're good. So I think this is a big crux of one of the, you know, conundrums that we encountered as we were starting to think about how to distribute remdesivir. And a lot of this was from the ethics feedback and things to keep in mind. I'll go over what I talked about again, but, you know, point 1 is the big thing. We're not trying to discriminate anybody. We want to look at all patients as they come in as the same and approach it that way. So, you know, factors like race, gender, you know, socioeconomic status, religious preference, whether they're a citizen or not, you know, sexual orientation, disability, all of that stuff shouldn't be considered in the decision-making tree. Here, we have pediatric and OB patients included in our allocation for Remdesivir. They are both potentially also available through compassionate use. So our thought is, and we left it in both ways. You know, if they're able to get the meds through compassionate use quickly, I think then it's reasonable to go through compassionate use. But the thought was, if there's a lot of challenges med and you're waiting 2-3 days, that's unacceptable for these patients that are getting worse. You should be using your allocation, because what's the point of saving the medication when it's there to try to save patients' lives in this setting? It should not be perceived on social worth or quality of life. And I'm going to come back to that question or that point. That actually came up the very first patient we looked at, and we had a little group discussion within our multidisciplinary group when we were looking at patients on point 3, just from a philosophical standpoint. Age and disability, which we'll see we had struggled with our ethicists on including age or not, but we didn't want to make age a discriminating factor, but we threw it in there as although we're not using it as a strict criteria, it can be used as a secondary component when you're looking at medical prognosis of patients, for example. So, if you have somebody with COVID, they're on the vent, for example, they're 98, they have multi-organ failure, they've already coded maybe once, that may not be somebody, given their age, that you may tier as high, so to speak, because their prognosis for recovery, regardless of the COVID infection, is already quite low. Another point is number 5, which is, I think, quite important, is the medication shouldn't be saved, for future concerns. You should be using it. And, that was something that everybody thinks about. You don't have enough resources. We should save these resources, or we should save it for somebody who's more ill down the road potentially and not use it right away. Well, then you're just having a medication sitting on your shelf and not helping anyone. So, that was a really strong point. If you have the medicine, use it if somebody needs it. And the decision tree should obviously be reviewed regularly so that distribution's appropriate. So if there's new literature coming out, that should update in your allocation algorithm. And then Remdesivir needs to be based on patient needs and obviously evidence-based criteria by a multidisciplinary team here at this point.
Oh no, it's Riverside listening to this.
So
Susan couldn't listen.
Oh,
So what's up?
nothing much.
Yeah.
So I did want to let you know that they're ruling out of.
Okay, so going to the next slide. There you go, Dr. Wang. Oh, I think he got muted.
right.
There you go. You're back.
All right.
Okay.
I was listening to the phone conversation, wondering which way it would go. So with the inclusion and exclusion criteria, you're probably still going to have patients that, especially when your supply is quite low, that you're probably going to have more patients meeting criteria than available treatment doses. So based off of ethics feedback, and this was applicable even to another scarce resource documentation that we had created our RUHS in regards to the concern for lack of ventilator use, but you'd tier patients based off of those that you have the best outcome for based off of the evidence-based medicine and studies, and go down the tier. So for example, if we had 4 doses but 5 patients that would qualify, you would look at those 5 patients and tier them essentially to see who's tier 1, tier 2, and tier 3. And the first tier would essentially get first dibs, so to speak, on the Remdesivir or whatever scarce allocation you had. So the Terran system came about because the P to F ratio we're looking at 2 to 300. What we're trying to do is target those patients that are getting more ill, progressively becoming more hypoxic, and but not yet at the ARDS where they're needing to go to the ICU and being intubated. Once you get intubated, we know the mortality rate goes up. So that's that group of population, especially with the most recent study, that has shown to have the most benefit. Also, the absence of chronic conditions shows better outcomes. So we're trying to, and then the symptom onset, where we said initially 12 days for a screen, well, now we're being even more strict in this first tier and trying to see who's got earlier onset of symptoms. Because again, as we know, earlier therapeutic intervention demonstrated better outcome as well. So we're trying to optimize the tier to target those patients that, number one, aren't in full respiratory failure or progressive significant respiratory failure, don't have significant comorbidities that would increase their mortality risk and recovery chance, and then having a more stringent requirement in this first tier now with symptom onset after they've passed the first criteria 12 patient. Tier 2, we then move down to the mechanical ventilation, where you're trying to target people who have not been on the vent for a long period of time. And again, absence of chronic conditions, which we'll go over really quick at the end there. And then everybody else would fall into a third tier, and what you would stratify within this tier is target people in group A first, who have major comorbidities, but have a prognosis of survival greater than 12 months. And then if there's nobody in that group, you'd go to tier B, which is the presence of severe life-limiting comorbidities, where they may have a life expectancy less than 6 to 12 months. So this was essentially significant input from ethics on how you could potentially tier patients and target people that are going to respond the best to the therapy in this situation. Next slide, please. So this essentially is just a summary of essentially what we put in there. Bullet number 3 is actually an interesting point, and we haven't had to do this yet, thankfully, but if you have more patients that are tied within a tier or just they're equal and yet less doses, then what they would default to after that would be essentially a random lottery that would be performed, you know, whether it was just randomly pulling a name or MRN out of a randomized protocol, whether you wanted it to be just out of a hat or whatever, and this would be from a third party that was not involved in the decision tree. When we give remdesivir to everybody, we don't have to consent them. This isn't a clinical trial, but there's a fact sheet that needs to be given to them and reviewed with them, and then that goes in the chart of every patient, so they have it available. And pharmacy keeps a very strict inventory and check on the medication as well. I think they have this locked up actually in like another lockbox in the scheduled meds lock area, so it's almost like triple locked or something like that. And then this is the table talking about chronic conditions. So the left side is your major comorbidities that could significantly decrease long-term prognosis survival, but these would have potentially still greater than 12-month survival. And as you can read down on the right side, these would have, you know, chronic conditions that have severe limiting survival times of expectancies, 6 to 12 months, or even potentially less at this point. So that was the entire kind of decision tree. And, you know, at first when we got remdesivir, we were still very excited, but as we thought about it and we thought about the lack of supplies, we said we had to come up with some sort of a as fair process, but still targeting the people that this medication is going to make a bigger difference for. You know, if we had to end the supply, I think everybody with COVID probably would be getting the medication regardless, but that's not the case here. So that's the last slide I have here, I believe. I don't think I have anything after this slide. And what I wanted to kind of talk about was the challenges that we went through with our first couple of patients when we had only the 4 doses of remdesivir. So we sat down as a group, and one of the first things we had was, you know, we came up with, when we were identifying patients, you're going to get in history, you're going to find out what, you know, their background, where they came from, their family, what kind of work they did, or maybe they didn't do work, or maybe, not to be more specific, but they might be coming from, say, some sort of a facility that you may have a contract with the county or whatnot. And you know, the question, you try not to think about it, but then you think, well, this person's doing all this stuff for society with their work, maybe they're a healthcare worker or a public health worker, and this patient over here, their background is they've maybe done something wrong in their life, and wouldn't you want to prioritize this person who's potentially maybe contributing a lot to society and stuff like that? And that comes up in your mind when you're thinking about the decision tree of who to give the medicine to and who to not. And I think, like ethics had put in, we shouldn't be looking at what they've done. You should just be treating the patient as a patient. And I think by creating this, it took all of those, personal feelings and personal biases, at least as much out of the decision tree as possible, to try to make as objective a decision and distribution for the medication as possible. And, just talking to the other hospital facilities within not only our county, but say San Bernardino County, and just colleagues I know in other places, this is the same conundrum everybody came up with. Most of the exclusion criteria we come up with actually were almost very similar, if not the same, to not only other county hospitals that had Remdesivir within Riverside County, but even just talking to other counties and other state hospitals that just bouncing different ideas off of. So that was very reassuring that the plan we came up with was very in line with what other physicians and groups and multidisciplinary committees had in line, along with their ethics input. So, we weren't going out on a limb, and I think the reasoning we had was very consistent. But I think that was one of the biggest challenges. And then, as you're trying to eliminate or not include people, you can't help but be a person and look at the whole, their background. You're thinking, this patient definitely would qualify, but, they had, healthy children and a family, and maybe this patient didn't have any family, but they ended up getting the medicine over somebody else. And, that there's a lot of humanistic aspect that goes into this, where you can't remove being a physician or a healthcare provider, and that does create a lot of angst. One situation which Dr. Versio had brought up was, what if you only had one treatment? You've got a young pediatric patient that's maybe 12 or 16. They haven't lived their whole life. And yet you have another patient that maybe is in their 70s, maybe they're a marathon runner, so they're super healthy. You're treating both the same, but at the same time, who's to say who's right and which patient can get a medicine like that when one person's lived the whole life and the other person's just starting their life? I don't think there's a good answer in these, but that the whole protocol and algorithm we have come up with to try to help alleviate those conflicts that would come up. So we haven't had really too many of these, and luckily the government has distributed more Remdesivir. So right now we do have a supply. I wouldn't say a significant supply, but still a okay supply where I think it can get us through the next couple of weeks. I guess the last point I'll say is most people get filtered out through the inclusion-exclusion criteria, and I think it's provided me more input, and it's almost always with symptom onset. And I think most of the patients are coming in with very indolent symptoms initially, and it's not till a week or even 2 weeks plus where they're really, really getting ill before they present in. So a lot of the patients who get screened out are actually due to the time to symptom onset, actually. So I'll leave it at that. Any questions?
Yeah, thank you, Dr. Wing. Yeah, I was curious to know what the most common reason for people being excluded, and wasn't sure if that was based on the timeline, which it seems like is what you're suggesting, or if it was based on the severity of illness with having multi-system, disease or organ failure. And so, yeah, just curious on how many of them have been screened out because of the multi-system organ failure.
We haven't had too many screened with there's been a couple in the ICU, but just all of them ended up getting screened out first from just symptom onset. And I think part of that, too, is when we got the Remdesivir, I think a lot of those patients who were on the vent for a long period of time, if we had the Remdesivir at the very beginning, those patients probably would have fit criteria to get it prior to getting to that point. So a lot of it had to do with when we got the Remdesivir as well.
Okay. And thank you for speaking to, I think all of us have these conflicts, especially with such a scarce resource of, wanting, being pulled, our heartstrings being pulled for a particular patient. And I think what has been really good about this document is really pulled that away from an individual physician or, and not force us to rely on any one person's kind of judgment about this.
Yeah, can I ask a question? When we received the first 4 doses, we had about 40 patients, almost 40 patients admitted in the hospital, and you identified initially only 2 that could benefit from Remdesivir. And I believe in our conversation with our colleagues in Riverside community, they had a similar experience where we all thought, hey, we're not going to have enough doses, and we found that there were less patients than we were expecting. Has that changed, or is that remain a little bit the rule that not a lot of patients qualified on the algorithms for the medication?
Yeah, that was a great point. Yeah, that was a major concern. As we've gone forward, we've, like Dr. Versio noted, although we haven't dipped down with the number, quite a bit of inpatient COVID patients, we have seen, our numbers going from 40 to 30, maybe fluctuating between high 20s to low 30s now. And because we're doing daily reviews once to twice a day on these patients, and we're not getting as many positive COVID patients come in what, like, say, a month or 2 ago, it's almost like we're getting about 1 every other day right now. And again, it comes down to symptom onset. There was a patient we had evaluated yesterday who I thought may have been a good candidate, and then talking to the patient, they ended up having a history where they weren't feeling well for over 2 weeks, and it just gradually got the respiratory symptoms gradually got worse. We're needing hospitalization within the last few days, but almost all of them still end up not meeting requirements due to symptom onset, which would be consistent with our colleagues across town. And then secondary, of course, a lot of them end up getting some liver dysfunction or coming in with renal dysfunction. So that also unfortunately screens them out because of the risk of more risk for those patients with complication of the medicine at that point. But yeah, it's probably about 1, maybe every day to every other day, unless we maybe get a slew of whole new positives at this point. And I think maybe that also lines in with just the public fear of wanting to come into a hospital or healthcare facility of exposing themselves. A lot of these patients and families I've spoken to all tell me that they would have came in sooner, but they were afraid that maybe, number one, that their family member, number one, might have gotten better, and then number 2, they were also afraid that if it wasn't COVID, what if they came in and then caught it? So there was also that factor in delayed presentation as well.
Okay. So just wanted to briefly speak on the pediatrics aspect of this since I'm involved with heavily in pediatrics. So there's 2 things that are unique about pediatrics with this. One is that there is a compassionate use pathway for both pediatric and OB patients. And so Gilead does appear to have some supply available for this. The other thing that's interesting for pediatrics is that it is only approved for those under 40 kilos to receive the lipophilized version of Remdesivir, which is not the version that's been distributed by the government. And so the kind that we have available in the hospital is only available for those over 40 kilos. And so what we've done, or what we're intending to do, is any pediatric patients will pursue the compassionate use pathway. If we're not able to obtain Remdesivir through that pathway, but we have a stock of Remdesivir at the hospital, then they would go into the resource allocation document and see if they could be allocated that resource. So, all right, any other questions that anybody has for Dr. Wang? All right. Well, thank you so much for joining us this morning. I hope that this was helpful for you, and we look forward to future webinars.